have four wonderful We have four wonderful panelists with us today. The first, as I mentioned again, Genentech, who we thank greatly for their support of this webinar series. Genentech is a biotechnology company and a member of the Roche Group. We are thankful to be funded by their new initiative to promote health equity and diversity in STEM. Here today to talk about their regional and local patient advocacy is panelist Rachel Israel. She's the director of the Regional Patient Advocacy Relationships in the Chief Diversity Office at Genentech. She has been with Genentech for over 15 years and working on oncology, rare diseases, and immunology, all while fighting for the cause of health equity and equal access to healthcare for all her patients. Her insight and passion have helped guide Genentech's work in health equity and patient inclusion. So thank you so much, Rachel, for being here with us. Our next panelist, we also have Dr. Chiquita Collins, who is Vice President for Diversity, Equity, and Inclusion and Chief Diversity Officer at UT Health San Antonio. She has worked to advance diversity, equity, and inclusion for decades and has taught diversity and bias trainings at the university. And then we're also delighted to have Dr. Jabran Pasha, who's a physician and Chief Executive Officer of Unblocking Implicit Biases, a workshop that he's given to over 100 times across the country and internationally. So we're really grateful for you joining us. And last but not least, we're delighted to have Dr. Loriana Hernandez Aldaman. She's a journalist, a two-time cancer survivor, and a founder of a nonprofit called Armor Up for Life. So these are the individuals that you're going to be meeting with us today and sharing their perspectives. So at first, I'd like to invite Rachel to share a few thoughts. Thank you.
Thank you, Dr. Ramirez. I am pleased to share and join you today and share Genentech's perspective and approach to tackling implicit bias in healthcare. Every day, patients all across America are seen in doctors' offices. And thankfully, more and more patients are returning to routine healthcare visits and screenings. As you know, however, the patient experience is not the same for all patients in every community. We hear countless stories about health inequities, and we read much about different outcomes for marginalized and underserved patients in communities of color in particular. As an example, I personally know that patients in the Haitian Creole community in South Florida are not given the same opportunity to participate, for example, in clinical trials. Assumptions are made that they won't understand or that they just won't participate. Where you live should not determine if you live. At Genentech, we are deeply committed to centering the marginalized and underserved patients in all that we do. We hope to make a tangible difference in the lives of patients who need our help the most. So we're locking arms with other healthcare stakeholders, including all of you, patient advocacy groups, medical schools, academic institutions, healthcare coalitions, and community practices. Genentech has been on the forefront of diversity in clinical trials. We launched Advancing Inclusive Research 5 years ago. And we developed our external council on inclusive research, which includes founding member Dr. Ruben Mesa, director of Mays Cancer Center at UT Health San Antonio. With the input and strategic partnership, these D&I thought leaders, physicians, research experts, they really helped us build our pillars around diversity and inclusion. And for us, that means fostering belonging within our own walls, advancing inclusive research and health equity in our industry at large, and transforming society really through partnerships across healthcare, education, and within all communities. So let's take a look at some of Genentech's internal practices. So Genentech has required training for managers that are also available to all employees on the topic of implicit bias and cultural competency. These trainings really speak to understanding differences as well as intersectionality. Our corporate and charitable giving has a strong focus on community-based organizations, but more importantly, they're led by people of color. And we're focusing on the future, not just the here and now. And we know that representation really does matter. We're building the healthcare professionals of tomorrow by supporting students of color in STEM, the Future Lab for high school students, and through scholarship support. And now I'll touch on a few things that we're doing in terms of external projects and partnerships. So last year, we launched the Advancing Inclusive Research Site Alliance, a coalition to increase diverse patient populations in our oncology clinical trials and establish best practices that can be leveraged to achieve health equity for all people. Genentech is also supporting a team at the University of California in San Francisco who is leading an initiative around combating unequal treatment in healthcare through virtual awareness and training in empathy. This is a very interesting program, and they include learning modules called Cultivate, which are a way to build empathy among healthcare professionals, allowing them to experience the healthcare system from the perspective of a middle-aged Black woman and a Spanish-speaking Latino man, including provider interactions that feel disrespectful, scary, and even uncomfortable, or someone whose language and culture are not well understood. And finally, we know that Black principal investigators are awarded funding roughly half the rate of white principal investigators. So we're doing something about that as well. We're supporting Black principal investigators with funding and mentorship by partnering with the University of Michigan and the University of Washington, who have assembled over 250 female faculty members across the country to champion more equitable research funding. And this includes specific calls of action by federal agencies to address racism and within funding practices. So these are just a few of the ways that Genentech is positively impacting patient care by tackling implicit bias and systemic racism in healthcare. At Genentech, we firmly believe that embracing diversity and inclusion drives innovation, it improves scientific and clinical outcomes, and it contributes to equitable healthcare access for all. So thank you so much for your time today. Thank you so much, Dr. Ramirez, for leading this wonderful panel discussion today.
Oh, Rachel, thank you so much for sharing those exciting initiatives that are being led through Genentech's support. So thank you very much. I had a quick question before we move on to our next panelist. How does your role and the team at Genentech support patient advocacy?
That's a great question. So about 18 months ago, we launched a regional arm of our national patient advocacy relations team. So not only do we have our national leads that cover the entire portfolio, but now we have a regional team that can work more locally at the local level. And this is really, really an outstanding opportunity for Genentech, because now we can work on both ends of the spectrum. And also we can work with local patient advocacy groups that are really working at the local level to transform communities.
Thank you. Really appreciate that. Great. Now I'll go to Dr. Collins. Dr. Collins, will you share your perspective on DEI and why it's important to university and healthcare providers?
Thank you, Dr. Ramirez. I am ecstatic to join this prestigious panel to share some perspectives on what we do here at University of Texas Health Science Center, and look forward to our conversation in terms of Q&A. So I think it's important for us to begin with understanding what implicit bias is. You know, I identify myself as an African-American woman, a woman of color, and I would say I am the most egalitarian person that you ever encounter. However, I have bias just like everyone on this panel, everyone who's joining us today. And so it's important to realize that although we have biases, what do we do about mitigating biases? And so hopefully we'll learn some pearls of wisdom today in terms of how we can empower individuals to really be upstanders in advocating for mitigation of bias. I think it's important also to illustrate that microaggressions is part of the rubric in terms of understanding how some people are victimized or targeted in terms of stereotypes, whether we're talking about racial stereotypes or how you self-identify if you've actually are seen by society in terms of being marginalized. So these are just some examples you may have experienced yourself, or you may have observed others being subjected to, okay? It's important to also understand the intersectionality. It's not saying that you have one identity versus another. We have multiple social identities, right? And so we have to also recognize and be mindful in terms of the extent to which intersectionality also plays a role in terms of the prejudice and stereotypes and discriminatory behaviors that exist in our society today as well. Now, in the context of a provider providing services to a patient, we live in a very fast-paced society, right? And we have to understand that our providers are often exposed by high levels of stress. We talk about physician burnout. They are undergoing high levels of time pressure, you know, in terms of providing information in terms of electronic medical records. They're multitasking. And so they are dealing with high level of obligations and really have to do this in a very short amount of time. Now, that doesn't give them a pass or an excuse in terms of engagement of biases, but it's important to understand that. Implicit bias is not reduced by good intentions, right? Because sometimes you have to view individuals coming from good intentions, but they often, unfortunately, sometimes engage in inappropriate behavior. It's not reduced by someone else telling you to reduce your bias, right? You have to have the skills, the wherewithal. And some of the toolkits that I'll produce or introduce today are useful in terms of mitigating bias and how do we suppress bias. We can't just assume that individuals, you know, will do this on their own. And so we have to provide evidence-based resources and tactics by which one can utilize. It's important, although in the interest of time, to really understand the plethora of studies that have been produced in research, mostly in social science research, but nonetheless, it's important for us to be cognizant in terms of looking at the evidence that has substantiated that bias exists and unfortunately has impacted a variety of different outcomes as pertains to health equity and health disparities. And just to give you an idea, you know, in terms of the extent or the pervasiveness of health disparities in our world today and how it disproportionately impacts communities of color, our biases have contributed to that reality. There have been studies mainly by Dr. Lisa Cooper at Johns Hopkins who have shown that provider-patient racial discordance has also contributed to the high rates of health disparities, and bias plays a role in that as well. Studies have shown that lower patient satisfaction has been attributable to bias tendencies. Emergency room departments or emergency medicine departments are less inclined to administer pain medication on the basis of biases that are so prevalent that are targeting both our Hispanic, Latino, Latinx patient population, as well as our African American and Black population. Many studies have utilized vignettes in the course of peds as well as adult patients and have shown that our doctors have a tendency to have biases towards, again, those two groups. One tool that has been highly advocated and to really be used as a tool to increase our awareness is the implicit association test that was created by Dr. Mahzarin Banaji, who's at Harvard University, along with her collaborators, Dr. Tony Greenwald at the University of Washington and Brian Nosek at the University of Virginia. Over 500 million data points have been verified that biases exist. And in fact, there are over 13, my last, I would say in terms of, I'm sure there's probably more, there are 13 IITs by which you can take part in. I always recommend there's one on race, there's two on gender, and there are others such as sexual orientation. Essentially, you are presented with a task by which you are shown pictures that are either ascribed a negative or positive adjective, and the pace increases over time, and you use your two index fingers from each of your hand, in which you have to make a decision based on what you see. And so at the end of that activity, it produces a summary and it indicates in terms of where you stand in terms of bias. It pertains to that specific implicit association test. Okay. Now, again, there are many studies to provide evidence that bias is not only targeting our BIPOC populations, Black, Indigenous, and persons of color, but also we find it for other marginalized groups as pertains to transgender, LGBTQ plus A patients, women, and others. And so again, it's important to know the data in terms of what exists in terms of evidence. All members of the healthcare team can benefit from a better understanding of and sensitivity to how implicit bias can present itself in patient care situations. Now, I want to flip the script in terms of, we've been talking about the extent to which providers may have biases towards certain groups in terms of patient populations.
Dr. Collins, excuse me, before you continue, can you place your slides on full mode?
Sure.
We're seeing the next slide. We just got a couple of comments on the chat box. Thank you so much.
My apologies. Let's see here. I'm not sure if I can actually change it to that. I apologize for that.
No problem.
How's that?
Thank you.
Perfect. Is that better? Okay.
Yes,
I apologize for that. Okay. So I was just beginning to mention that we've been talking about the direction by which provider has biases towards patients, but it can also be the opposite way, right? And I think it's important to mention that. There's been an uptick in the last 5 years by which hospitals have documented that patients are actually expressing rude behavior towards providers. And so we have to be mindful of that as well in terms of the context of understanding bias in the healthcare system. Now, what can we do, right? My goal is to empower individuals, right? And so there are many tactics that have been shown in the literature that have been effective, right? So it all depends in terms of your comfort level, right? We always say that the best advocate is yourself, but depending on where you are in terms of power dynamic, that may or may not be most appropriate, right? So these are some examples in the slide. I'm open to have conversation as we actually engage in our Q&A. You can reframe the question. You can ask the person whether or not you understood what that person was trying to say, and maybe they can have an opportunity to reinterpret or reconvey. That might be more straightforward. And so you don't want to make assumptions based on what has been shared. But again, everything is in situational context, and you have to explore that into greater detail. We train our physicians. In fact, we create a hand pocket for them to use as a reference guide, and utilizing what we refer to as the charge square mitigation process. And we can talk more about that in our Q&A. And essentially, again, is to use as a reference guide, as reminders, because it takes time to really master many of these tactics. And so it's important for us to provide some kind of quick guidelines by which they can use as a reference in the context of providing health care. In addition to that, there are various toolkits. One is referred to as the interrupt toolkit, and that is, as you see here, in terms of the acronym being spelled out. I is to inquire, ask. Whether or not the situation is non-threatening is something to inquire as well, to take responsibility, to empower, to reframe the question or to redirect the question, to use impact questions, and to paraphrase, and always come from the point of view in terms of I phrases versus we. 4 buckets, I would say, that we are elevating here at our university is to really remove ourselves from making assumptions in terms of a collective voice or collective perspective, to, I would say, really try to engage in terms of the view of that person that's in front of you, right? Not necessarily, we're not this homogeneous type of population. And so you have to really individualize the extent to which you have an exchange. Second is to really have a perspective taking, right? Take a conscientious attempt to envision another person's viewpoint or take the other person's shoes, right? We try to encourage that sometimes you have to remove yourself from your comfort zone and begin interacting with people who are different from yourself. And then you find out that we have more in common than ever before. It's important for us to also to diversify our biomedical workforce. And we see in terms of our pipelines that we're making inroads, but we have a lot of work to do. Last but not least is to encourage mandatory training throughout the medical education spectrum, not just in terms of putting all of our energies in terms of our students or learners, but throughout the spectrum. So even after you pursue residency or fellowship or become a practicing physician, you have to continually learn in terms of ways in which we can better ourselves in mitigating bias. We created a variety of toolkits. We have an upstandard action guide that's made available to our physicians here at the university. We've offered a microaggressions train the trainer program, of which we've trained over 1,000 individuals within our medical enterprise. And so that has been highly received. We test everything that we do in terms of making sure that we have efficacy in our effort. And so we have found that we've made significant change in terms of increasing educational awareness as well as behavior. And here's some of the data to illustrate that. Last but not least, bias training typically focuses on raising awareness, changing either bias attitudes and behaviors, but it's important to walk away and say we have to make sure that we engage in all of those types of ways in which we can, again, get to the point where we're not discriminating individuals on the basis of any of those social identities. And so we have to make sure that we continue our training again throughout. I'll conclude there and I look forward to our discussion. Thank you for the opportunity.
Great. No, thank you very much, Dr. Collins. Really very informative. Just a quick question for you. How does implicit bias training at a university differ from other settings?
I think you have to target it like any organizational context, right? And so we are adhering to a tripartite mission as it pertains to providing education, those who are engaged in research, as well as those who are, as pertains to, what am I missing? Education, clinical care, and research. So all three of our tenets, we have to make sure that we're providing biases in that context. So we have to target to ensure that our researchers, our learners, our practitioners are engaged and have the wherewithal in terms of the tools to be able to mitigate bias. And so we provide online training as well as in-person training. And so again, you have to tailor it according to your organizational culture, but there are many things that are duplicate, but there are things that are unique as well.
Great. Thank you so much, Dr. Collins. Really exciting work that you're doing and so glad you're with us. Our next speaker is our cancer survivor and advocate, Dr. Loriana Hernandez Aldaman, and she's going to share her experience with us in going through some of her treatments. So Loriana, thank you.
Thank you so much. Let me get to my slides. See if I can present. All right, so anyway, thank you all, and it's just an honor to be here with such an incredible panel. Like Rachel and Dr. Collins just mentioned, that implicit bias, unconscious prejudice is not unique to healthcare. None of us are immune to it. And I like how Dr. Collins mentioned that this can go both ways, provider and also patient. But while implicit bias affects nearly everyone, we know when it happens in the healthcare setting that it can just change a patient's trajectory and their patient outcome. But before we talk about provider bias and the impact on patients and the steps we can take, since this is a webinar on health equity, I want to share a few things. Patient outcomes, we know, are more, according to statistics, than just following doctor's orders. 80% of health outcomes are not due to a patient's medical factors, but rather the socioeconomic ones: race, income, insurance, zip code, education, implicit bias, of course, compounding all of those problems. And we're talking about the poor treatment, receiving inaccurate diagnosis, experiencing delays in diagnosis. I want to share something. I'm always at the doctor, being a leukemia survivor and a bone marrow transplant survivor and breast cancer survivor, and having moved a lot. I've changed healthcare systems a number of times. 2 weeks ago, I was sitting in the lobby at my oncology center, and I look over and I see this, and I had to take a picture. Now, I wiped out the organization's name because I thought that's not important. The important issue is to say, I'm like, whose hands are at the heart of our work? It's really important to take a look at it. And I started to say, the journalist in me, the marketing person in me said, well, clearly this is a misstep in marketing because it's not just white males who are the hands of the heart of our work. This was 2 weeks ago. This isn't an old slide from a long time ago. But the reality is that this is pretty factual. According to Salute America, which they presented, which Dr. Ramirez presented at the Latino Cancer Conference I was at, hospital leadership is only 2%. Latino nurses make up 5.7%. Latino doctors make up only 6.3%. And Latino medical students make up only 6.9%. Studies have found that increasing the number of physicians could reduce the impact of implicit bias. As Dr. Collins said, as Rachel said, this is not going to make it go away. We're all have to work on our own implicit biases, but this having the healthcare community and our care teams reflect who we are would be a great step to see a multicultural hand, men, women, Black, brown, all different races. So that is an important step for me. The next thing I want to share is a little bit about me and why you might think, well, who is she to be talking about all of this? Well, I'm a proud wife and a mother. I'm honored to be here and be alive. I'm an Emmy Award-winning journalist, a medical and fitness reporter, and a healthcare coach. And I am a 2-time cancer survivor, leukemia, bone marrow transplant, and then on the 5th anniversary of surviving that pivotal day, I found out I had breast cancer. To my son, I'm a superhero. And in many ways, I felt like I had to become a superhero to overcome all the healthcare disparities, even with all the connections I had. And I always kept saying throughout my journeys, you should not have to be connected to improve your patient outcome. But the reality is part of that reason, it's why I'm here. I'm also your 1 in 4. I was given from the healthcare system, and I was at a world-renowned healthcare system at Johns Hopkins, and they said you have a 1 in 4 chance of surviving. And that's if you're German, not Cuban, because they didn't have statistics on how a Cuban might do, even having trouble finding a donor for my bone marrow transplant. So through all of this, through my 2 journeys, I said that these were the biggest stories of my career, having uncovered a system, so many systems operating in silos and healthcare disparities, the transportation, the childcare, the finances, the patient experience, the health literacy issues. And again, I came in as a medical reporter, very well connected with a long list of people I could call for help. And I always worried about what are other people doing if they're not connected? They don't have access to the people I might have access to. The clinical trials, their recruitment strategies, and no psycho-oncology care team to help humanize this, which we know in the Black and brown communities, when you go through the mental side of cancer, we can improve patient outcomes. But when we have implicit bias, again, it complicates the whole thing. So I always say I made it, one, because I was at a world-renowned institution, and anywhere I move, I still fly to go see them because I have so much trust in the system there. And they made up for the lack of statistics that they may have had, but I also had to become my own hero. I was pushy. I was a pushy reporter, always pushing for answers and not taking no for an answer. And if I felt there was bias, I pushed again and pushed for answers. But every scenario, even today in my journeys, what disappoints me is I always have to go into every doctor's office and say, I'm an Emmy Award-winning journalist. I'm a former medical reporter. I have a lot of connections. I'm a patient advocate. I know, and you shouldn't have to roll out your resume, your CV of who you are to improve your outcome. It's not right. But with that, even with that setup, I would say that I still was not exempt from implicit bias, medical gaslighting, and it worries me when we talk about the underserved communities, those who can't speak up for themselves, who can't push their way through, even when there is that bias in place. Grateful for the heroic team at Johns Hopkins. Studies still show, as Dr. Collins said, that female patients of color are more likely to have their symptoms dismissed. So many times that has happened to me, especially when doctors see on the medical charts, she has cancer-related PTSD, high level of anxiety and depression. Then it's always, okay, she's depressed, she's worrying about this. No, this is very real. Pain meds more readily available to white patients over brown and Black patients. Patients of color receiving fewer cardiovascular interventions. What happened to me that was the most difficult was when I left Johns Hopkins, which I felt really raised the bar in so many things, and I had to move, and I had my double mastectomy at another pretty well-recognized institution, but I was ignored at every turn. So many times I had the double mastectomy. I said, I have a lot of baggage. I know my history. And here I was going through with fevers. Nobody wanted to readmit me. I had to literally get somebody who was the HR, the head of HR for this well-known institution, on the phone with my doctors at Johns Hopkins to readmit me. Nobody wanted to readmit me. They said I was exaggerating and making a big deal. It turned out if I had an infection, I had to be readmitted for more than a week and get IV antibiotics. What would have happened if I did not push my way through? After a week in the hospital, I was admitted 3 times, 3 infections, 3 readmissions. The next time I called for help in the middle of the night at midnight, the doctor on call said, "Why are you calling with stomach pain?" I had a deep flap. "Why are you calling with stomach pain at midnight? Every patient who goes through this is in pain." I said, "This is not normal. I know my body. I was in the hospital for a year with leukemia. Something is wrong." Again, they did not want to readmit me. He told me to drink coffee. It's a diuretic. And again, I had to go back to, I am a former medical reporter. You're not going to talk to me like this. I have a problem. It took me going through HR, the HR contact I had, and other contacts who were physicians at the hospital, to get me in with a dermatologist oncologist because the physician would not do a culture. I had another infection. I had to be readmitted for now more than a week. I needed 5 months of home health care and an open wound in my breast that had to be packed. Time and time again, I'm watching the clock to make sure I'm not going over, but time and time again, even when I said I didn't like the appearance and they said to me, "Well, this is not a cosmetic procedure. You shouldn't expect to look good unless you have cash. This is creating breasts." And I would say, "Well, cancer found me. I didn't find cancer." So there were times, and so the reason why I share my story is because so many people fighting who reach out to my nonprofit, they don't want to be transparent because they're too scared to speak up. And I know I have a moral obligation that I lived, and I'm going to share what I went through to improve the journey for other patients. We need to turn the numbers around, as Dr. Ramirez shared at the conference, the Latino Cancer Conference. In the next 10 years, we're expecting a 142% increase in Latino cancer cases alone. You asked about the questions and the assumptions. Well, we need more questions, and we need to make less assumptions. I'm trying to get through this faster. I know my time is ticking.
You're doing good. You're doing good.
What can we do? Well, we can start with having healthcare teams reflect our community. It's so important, as I mentioned before. I'm trying to go through this as a reporter. I know there's a hard out on this. We do need implicit bias training. Let me get back to that slide. We need implicit bias training, cultural competency training, teamwork, diversity, equity, inclusion in our health teams. It's going to take work. As Dr. Collins mentioned, we also are dealing with this when we know the providers, who I have many who are now friends through these journeys, are overworked as well. There is burnout, and they're dealing with hours of charting. So it's going to take funding. It's going to take time. It's going to take a lot of work to get us there. But I just want people to realize we're not trying to point fingers. We do need that compassion. I know the minute I walk in and they see, as I had to find a new care team in my new city of Atlanta, and I walk in and they see PTSD, and I freak out when my counts are off because I don't want to go back to the hospital for an entire year, separated from my son again. And they say, "Well, what are you panicking about? Why are you being so dramatic?" Well, because I want to live and I have a son I want to raise. So we do need to shift the dialogue and not ask, "Why are you being dramatic?" And it's not just race for implicit bias. It's your weight. It's your emotional well-being. It's how you are perceived in the doctor's office. And again, before I go, I don't want to point fingers just at the providers or the nurses. They're heroes. You're all heroes. But also the patients need to work on that too, because there needs to be the level of respect. You are our heroes and you're there to help us. And we need to be our own hero to help ourselves as well. So my nonprofit's Arm Up for Life, we work on prehab, risk reduction in the underserved communities. We're a 501c3, and we focus on preparing, presenting, prevail. So we can prepare everybody for illness so they can present well to their medical team and position them to prevail. I think I got out 40 seconds over, and I'm sorry.
No, amazing, Loriana. You're just such a wonderful individual that we love hearing from you, and your passion in helping us build that bridge, right? As you just said, it was really hard. I was asked a question recently. It says, well, healthcare providers have biases, and I said, yes, some do. And some are there to, and most of them there, as you so well said, are all our heroes. We need to work together, and we need to,
Right.
to really exchange that information, but for them to see us equally, regardless of the color of our skin. And so thank you very much for sharing these remarks. I have a few questions for you, but I'm going to come back, and we're going to have Dr. Gibran Pasha present his information, and he's done some amazing work on unlocking the implicit bias. So thank you so much.
Thank you.
Right. See, I'm gonna share my slides here. I think I have to have permission. It's not letting me share. I'll try again. All right, here we go. So what I love about what Dr. Collins and Loriana started with is the fact that although at this moment I'm the person in front of the group with the expertise, this is a journey that I am taking as well. And no one is able to avoid having these biases. And that's actually why I got into this. And if you were to ask me, 6 or so years ago what implicit bias was, I could have maybe stumbled through a definition. But upon learning about implicit bias, 2 things struck me. The first was that everybody has it, whether we're willing to admit it or recognize it or not, we all have it. That was the first thing that struck me. The second thing that struck me was that as a physician, undoubtedly there are times where my biases were coming in the way of me providing the best care possible for my patients. And once you come to that realization, because as was already mentioned, we have these egalitarian views and we want to be the best we can be, these biases get in the way. And so I started this journey to really help myself and to help my patients. But then I realized, hey, this is going to help the patients that I'm going to touch, but how can I do more? And I consider myself as much of a teacher as I do a physician. Every single patient encounter that I have is with learners. So I have medical students and PA students and residents on my team every single day that I see patients. And I said, I can probably make more of an impact teaching about implicit bias than I can about teaching how to diagnose heart failure or treat pneumonia. And so that's what threw me into this space. And you fast forward, 5 years later, I've done this 120 plus times and learned a lot about myself. And I think what really continues to motivate me to do this work is this very simple cartoon. And I saw it at first, it made me think of when I was a little boy sharing a room with my brother, and this is how we cleaned our room. We sweep everything under the bed, we push everything in the closet. Our mom would definitely disagree with our room being clean. But this also reminds me of how as a society, we have faced social issues, difficult conversations. I do think now more than ever in our society, we are peeling these rugs back and actually addressing what lies beneath them. And that's what it takes. The more we have these difficult conversations, the more that we find the courage to lean into discussions like the 75 plus people that are on this call have decided to do today. You are, whether you realize it or not, you are peeling the rugs back and starting to face these issues. It's never going to be easy. I would never try to convince you that it's easy. What I would say is congratulations on being willing to have these difficult discussions. And so this is my life. Almost every day I'm having these conversations and it's not easy, but it's worth it. And so thank you everyone for being willing to continue these discussions and take this journey. The reason why I do it every day is this very simple pie chart, and Loriana shared a statistic that I wanna underscore. As a healthcare worker, someone who sees patients almost every day it is oftentimes hard for me to come to the realization that the healthcare that I provide for someone only accounts for about 10% of their health. That's it. And it doesn't mean that when someone is acutely ill, they don't need healthcare and that seeing a doctor won't save their life. It doesn't mean that. But it means as you zoom out and you look at the bigger picture, what contributes to someone being healthy or unhealthy is much more than healthcare. And the best analogy that I think I can pass along, I wish I could say I made it up, I didn't. But the best analogy that I can think of is we've all had a headache, right? We've all had a headache before. And let's just assume that when we get a headache, we can take Tylenol and that Tylenol takes our headache away. That does not mean that our headache is due to the lack of Tylenol, right? So why would it be the same way with healthcare, right? When we're sick, we go to a doctor, we get healthcare, and we get better. But that doesn't mean we are sick because of lack of healthcare. There are a lot of other factors that contribute, and these social factors or social determinants of health are major, and they make up about 70% of why someone is healthy or why they are healthy. And within that is the idea, the concept of implicit bias, because as was already pointed out with a lot of the statistics, the biases of healthcare workers shape the health disparities that we see. And so that's why this work is really important to me, and that's why it's important for anyone who is in healthcare to learn how to become more aware of their biases and learn how to mitigate their biases. I will say that I feel quite strongly that no one should feel ashamed or guilty about the biases that they have, because everybody has it. It's literally a part of being human and part of the human experience. And so we don't need to use that shame and guilt as a barrier for us having these conversations and talking about it, because we shouldn't feel ashamed about it at all. But that doesn't mean that the impact isn't very real. And I think it's important to differentiate implicit bias from explicit forms of discrimination. Very different. It's not the same thing, right? Implicit bias is not the same thing as racism or sexism or ageism or whatever other form of explicit discrimination. It's not the same thing, but I think it's arguable, and I feel pretty sound in saying the impact of implicit bias in healthcare is greater than the impact of explicit discrimination. So these are things that we just have to address. I'm going to keep it brief, but I want to leave with this discussion because I know we, as researchers and scientists, as we tend to do, we can focus on statistics a lot, and I talk a lot about statistics in many of my workshops. But on every end of each statistic is a human life. And I want to share a heartbreaking story of a young woman who was just 36 years old. I'm 30, I'll be 38 next month. I have now lived longer than she was able to. And this woman, Shalon Irving, was a first-time mother at 36. She was beyond herself about having a child, and she began to have some issues, some symptoms right after birth that led to her going to see her OB on several occasions with complaints of her symptoms. And she was assured, this is normal, there's nothing for you to be worried about, go spend time with your baby. On the third time that she visited her doctor with complaints of shortness of breath and swelling, she again was dismissed. She cardiac arrested 3 hours after that appointment with her physician. She was on life support for a short amount of time, and her mother had to make the unbelievable decision to withdraw care, and she passed away. I want to be completely clear that Shalon Irving's story is not unique. Because we know that Black and brown women, especially Black women and Native women, are 2 and 3 times more likely to die from childbirth-related complications. Her story is not unique, but what makes her story so, I don't even know the word to put to it, but what makes her story so unbelievable is actually more about who she was. She was a brilliant woman. She graduated high school at age 16. She went on to get several PhDs, gerontology and sociology. She went on to get a master's in public health. She worked at the Center for Disease Control as an expert in racial health disparities. And as Loriana mentioned, if this lady was unable to advocate enough to save her own life, how unbelievably difficult would it be for someone who doesn't have the education, the knowledge, or the resources, right? And so this story tells us how real these biases are and how much of an uphill battle we have. And so I always want to share a human story when we have these discussions, because this is why we're doing it. This is why we're having this panel. And I'm honored to try to do my part and do this work and offer trainings to people in and outside of healthcare to help us better recognize the biases that we have. And so I will cut it off there, and hopefully we'll have some time for questions.
Great. Thank you so much, Dr. Pasha. No, it is those stories that impact us greatly, right? And it's why we're trying to make a change. Research now shows that this is something that exists, and we need to make lives better by taking a look at what's causing this. So thank you for that excellent presentation. A question for you. Have you personally experienced implicit bias, and how did it influence your workshops?
Oh, every day, almost. And I don't mean that as hyperbole. I think, as we know that Black physicians only make up 2.5% of doctors, Black male physicians. And I can almost say almost every day I walk into a patient room with a stethoscope on and scrubs, and I'm handed a tray, or I'm assumed to be a non-healthcare worker. So that happens every day. But I want to actually go back to a story where I didn't know it was implicit bias at the time. And this was when I was in college. I went to the University of Kansas. It was book buyback week. So I was taking my textbooks back to get pennies on the dollar so I could have a little money in my pocket. And I walk into the bookstore with my stack of textbooks, and someone from across the room yells at me and says, "Oh, no, football players sell your books back over here." I wasn't a football player, but I was a Black male at a university, and that bias that if you're in college and you're a Black male, you're there for athletics and not academics. So I didn't know it was bias at the time, and of course I was really upset. Looking back at it, I realized that was implicit bias that impacted me and the person who made that suggestion. And so that's why I do what I do, because it's not about blaming and shaming people. It's about helping them understand that they can better be aware of the biases that they have.
Oh, great. Thank you. Thank you for sharing that. I was asked recently the question, when did I first feel discrimination? And in the Latino community, I grew up in a small border town in South Texas where we were the minority, not knowing it. And so, and I think Latinos, and maybe Loriana can add her comments to this, we're kind of considered this blended, so population, and sometimes our biases are more, or how people react to us are indirect. You don't know you're being told that, but then when they say, well, those Mexicans or those that, they're going like, well, that's who I am, and it's these comments that you really catch you off guard without realizing it. And so it's really interesting, but definitely our community has gone through some really difficult times as well. And this is kind of an opportunity for us to all recognize this, that we all need to address this issue. And as you so well said, that we all might have our own biases, and that we need to learn how to better deal with them so that we can have these true conversations. So thank you so much for your comments. So I'd like to open it up now to a discussion for all of you, and maybe to go back to Loriana. It says, what in going through some of your treatments, what assumptions do you feel were made about you that you had a difficult time to make sure you got the treatments you needed? You're muted. I'm sorry.
Oops. There were so many times assumptions were made, and some were at first when they heard, oh, she is a news anchor, she doesn't need help. And I said, no, we're about to lose our house. You can't assume because I had a great career that I'm not going to lose my house. And so at one point I was almost fighting for resources and help and ignored. There were other assumptions, again, when they see some of the cancer-related PTSD or the anxiety, there's assumptions that maybe that this patient is just, that they're working off of their anxiety and this is not a real complaint for pain and needing help. So many times when I was readmitted after my double mastectomy, and they said, had you not been here, you would have had sepsis and you would not have made it. So I always say, you heard me mention my prepare, present, prevail, which is my 3P protocol, but my fourth one is being a pain in the neck, because I feel like you have to work around those assumptions. And I know that, as Dr. Pasha said, it's not blaming and shaming. But I do sometimes go in with my guard up and I say, listen, here's who I am. I'm not going to be ignored. And the physicians look at me like, well, what did the last physician say to you that got you so upset? But I feel like we have to lay out our resume to say, to listen to us. But there's so many patients who call our nonprofit Arm Up for Life and ask us to help them. And even when they're sitting there, they feel like they're being ignored, but they don't feel right to even speak up. And that's what pains me. We had someone reach out to us who had throat cancer. They were told they had laryngitis. And I said, go back and say, this laryngitis has gone on for 3 weeks. You have healthcare, you're privileged for that. Go and see if you can get another test. Sure enough, I got this patient in with an ENT. They had throat cancer. So it's even giving patients the confidence to speak up when they feel the implicit bias is happening.
Right.
So it is education on both sides.
Thank you. We have a question from the audience from Julia Olaf. She's asking if the research on reducing implicit bias among healthcare providers offers insight on interventions that are more or most effective in bringing about positive change. So Dr. Pasha and Dr. Collins, have you all seen any specific research that highlights these changes?
One area that I've seen some of the best support for is simply expanding your circle, being around different people of all different backgrounds, quality individuals of all different backgrounds may be one of the best ways to undo some of those negative stereotypes that exist about certain cultures and certain groups of people.
Dr. Collins, would you like to add to that?
Yeah, I would like to add having meaningful relationships, right? Because in our workplaces, they tend to be somewhat diverse, right? But do we really take the time to establish relationships? So again, we'll find that we have more in common than we have dissimilar. And so we have to really extend ourselves, because coming from a social scientist perspective, we look at the United States and we are as segregated as we were when my parents were growing up. And we continue to be, because there's white flight. Once a percentage of the neighborhood becomes 0.1% Black, whites leave, and that's been documented. We have this perceived fear about each other. So I would hope, given what happened 2 years ago, that we have opportunity to have courageous conversations, to meet people in terms of where they are, and to be respectful. And we'll move it further along than we ever have when we begin to doing that.
Thank you. Thank you very much. A question for Rachel. What has Genentech accomplished and what does it still need to be done to help support our patients?
Thank you, Dr. Ramirez, for that question. We have accomplished a lot at Genentech, and we have been bold in our actions, and it starts with our employees, what we're doing within our own walls, and that is very important to helping our employees understand cultural competency and diversity and why it matters, especially for marginalized patients. And also in terms of our organizational structure, we are truly focusing not just on national advocacy organizations, but the team I lead is about transforming communities locally and working with community-based organizations that are led by people of color. We are also learning from you and your colleagues all across America, also working with medical schools tools, and really, as I said, earlier, focusing on healthcare providers of the future, not just today. We know that healthcare professionals have gone through a lot over the last 2 years, and we really want to be on the forefront of building that for tomorrow's healthcare providers. And so those are just some of the things, but I also think you have to start with your own house before you go out and do it, in the community. And we're doing that one patient at a time, one community at a time across America.
Awesome. Thank you. Thank you so much. Let me see. I think we might have a, nope. Okay. I'm going to ask each one of you a question. If you can kind of keep it to a 30-second response, that would be great. Okay. Dr. Collins, how can people become more aware of their own biases?
I think what I mentioned in my presentation, the IAT is freely accessible. You just Google it and you can utilize it. It's only a 5-minute activity. And again, you'll be enlightened. And so utilizing that and say, what can I do personally? That's the first start. And I would say introspection, right? Sometimes we have to dig deeper in terms of our own biases, our lived experiences really subject us to the way in which we behave, so we have to do some introspection in addition to utilizing some freely available tools.
Good, thank you. Dr. Pasha, what do people often misunderstand about implicit bias?
Yeah, I think they misunderstand it as an accusation that these are explicit thoughts and beliefs, right? As we hear in the media often now, different laws and bills coming up where you can't talk about this stuff because it makes people feel ashamed or guilty. I think it's just misinterpreted. People don't understand that we all have it, and it doesn't mean we're bad. It's just letting us know the areas where we need to work to be better.
Great, thank you so much. And Lariana, a short statement of what would you like to leave patients with? What kind of information would you like to empower them with?
Well, patients need to just be vulnerable in some sense if they can to open up. And hopefully on the other side, when we're talking about the healthcare institutions, that it just starts with awareness for all of us, whether it's the patient and the provider, and education, know that we do all carry these biases, and it's going to take time. And if we want to have change, we're going to have to work on it.
Great. Thank you so much. And I'm going to wrap us up, but this has just been a wonderful conversation with all of you. Thank you for joining us this afternoon. We want to thank all our participants as well. It's important to hear from physicians, survivors, and advocates who are doing this work to really help us take down implicit bias. So please share your stories with us. In this area of work, it's vital to be in tune with our community, which has been historically underserved. So again, please share your stories. And we must work to address these biases that lead to health disparities. And proper patient care means better chances of survival for all our patients. So thank you. We want to just let you know we have another webinar coming up on June 2022 on men's cancer screenings, and we hope that you will join us there. And then if you want some specific information on healthcare biases, please go to our Salud America website at salud.to/health biases. So again, thank you all for joining us today, and have a wonderful afternoon. Take care. Thank you.
You.
Bye-bye.
Thanks, everyone.